Thank you, Sandy. First of all, I want to thank Julio for inviting me and having me present today. My presentation deviates a bit from what is in the agenda, and it's also very different than anything that's been presented thus far. I'm going to be talking about a particular initiative at NIDA, and it's focused on how we can go about creating synergies across research in this particular area. There are different models for doing that. One of the things that you've heard people talk about today involves a large multi-site trial model. There are also models that have been developed where a common battery of instruments is developed and then everyone uses that common battery. But I'm going to talk a little bit about something that's different that has to do with data harmonization and data harmonization efforts around a particular funding initiative in the area of seek, test, treat, and retain. So this initiative focuses specifically on the criminal justice population, and I thought I'd spend a little bit of time providing a brief orientation. Tomorrow, there's going to be a much longer time spent describing this population and why they're important to seek, test, treat, and retain. But I wanted to give a little bit of background information. I actually changed this slide today after hearing people talk about the cascade. I mean, why do we focus on criminal justice in the United States? Well, it's an attempt to use involvement in the criminal justice system to enhance that cascade. In the United States, there are a lot of individuals that are involved, either within the community under some type of criminal justice supervision or actually incarcerated in prison and jail. In fact, there are around 8 million adults currently. That doesn't include adolescents. We also in the United States have the distinction of imprisoning more people per capita than any other country in the world, and there was a huge growth in the prison industry in the 1990s, much of it as a result of mandatory minimum sentencing guidelines related to drug-related offenses in particular. With regard to infectious disease, this is a population that has tremendous need within the U.S. In any given year, about 14% of everyone with HIV, 33% of those with Hep C, and about 40% of those with TB will pass through a correctional facility. We don't do a very good job of providing basic types of services, including HIV testing, TB screening, Hep C screening, and then any kind of HIV treatment and counseling within our systems. This is data from a facility-level survey. It's not individual-level data. It gives you no idea of how many patients actually receive these services. It just lets you know whether or not a facility is even offering them. So since we are well below the 100% mark, if facilities aren't offering these services, then you can imagine that there is a vast discrepancy between the number of individuals who would need these services and who are actually able to receive them. Within prisons, we do the best job. Part of that is because in the United States, there is a constitutional mandate that you receive health care if you are imprisoned. That is the only group of individuals within the U.S. until, and if health care reform is fully implemented, that has a constitutional right to health care. So you see that the best job of trying to provide any kind of treatment is within prisons, and we fall off dramatically with jails, and particularly with individuals who are within community correctional programs. We also know that while you are involved in the prison system, you may have a right to health care and you may actually receive antiretroviral therapy and be stabilized. Your likelihood of continuing with ART after you're released back into the community is abysmal. This is data from one particular prison system in this, which is located in Texas. In Texas, they give people a 10-day supply of antiretrovirals upon release to the community. Yes, that is 10 days. So within 10 days, you must refill your prescriptions in order to not have a disruption in treatment. And as you can see, less than 6% of the individuals experienced were able to do this. And even out as much as 60 days, only 30% had refilled their prescription so that they would not have a disruption in their continuity of care and within their treatment. I couldn't figure out how to get this slide that Julio sent me yesterday converted over because I'm not a Mac user. But there is a paper that has been published actually in the last couple of weeks on data here in Vancouver that looks at the burden of incarceration to adherence to antiretrovirals and the disruption that that creates in people's ability to actually maintain and adhere. So when we think about addressing drug abuse and HIV, I think it's important to have a perspective not only on the individual needs of your patients, but also a conceptual framework of the system within which you're working, so that you can try to match the interventions to what's happening within that system to have the greatest likelihood of uptake and implementation. So this is not necessarily intended to be linear, but it does provide a depiction of some of the events that occur, including entry into the system from arrest, prosecution, adjudication, sentencing, corrections, and community reentry. And there are different opportunities for both drug abuse treatment as well as seek, test, treat, and then particular needs for retain along this continuum. And I'll talk about those in just a minute. But there's also key players that are involved that it is really important to be aware of whenever you're trying to come into a system whose mission is not public health and trying to convince them, cajole them, or whatever you need to do in order to unite them in your ability to deal with the treatment of different types of public health diseases. Everything from prosecutors and defense attorneys and judges. I am very involved with an initiative at NIDA, for example, to train judges across the United States of the needs of drug abusing offenders, including their HIV treatment needs, to try to engage them and convince them that a part of protecting the public and public safety is also helping us to ensure good quality health care and protect the health of their communities. And then there's key intervention opportunities that map onto what is happening at those different points in time. So when someone's first arrested and they're entering the system, it's a time for screening and referral. It offers the opportunity to seek out individuals that may not formerly have been a part of any type of a treatment system. When they're initially in the early phases of involvement, there's an opportunity for testing. Then particularly if someone is going to be involved in being detained for a long period of time, you have the time that you need to treat. And then if anyone has been detained and they're moving back out into the community, retaining them in care becomes essential. So we had a funding initiative last year, and we have funded 12 different projects across the United States looking at the seek, test, treat, and retain paradigm within criminal justice. And the grants really focus on finding ways to enhance different components of that continuum of care. This is a map that shows you where they are located. They all partner with multiple and different criminal justice organizations, and we have funding from NIDA. One center is funded from NIMH, and co-funding from NIAID. There's 12 centers. They represent some of the largest criminal justice systems within the United States, some of the largest jail systems, including Rikers Island, Cook, and LA County, the federal system, the Federal Bureau of Prisons, the District of Columbia, both jail and probation, and then different state prison systems, including Texas, Florida, North Carolina, Connecticut, and California, where they have high prison populations, high drug abusing populations, and high rates of HIV. Here's a list of the grantees, including their affiliated organizations, and many of them are here in the room today, and so when we get to the question and answer section, they hopefully will be helping and participating as well. So this just shows a little bit about the continuum of services and care, and what's new really is the box in the middle for treatment, which involves looking at how we can facilitate the administration of treatment when people are in custody, and then the retaining, which is the linkage to community, because this is a population that, if you want to talk about migration, I suppose they're migrating. They're moving from their current stable housing, healthcare situation back out into a community where many of them don't have housing, don't have jobs, may or may not have family contacts, and don't have a national healthcare system to tap into. So they don't easily and quickly have the ability to regain care. So if we look across what the different studies are involved in, most of them move across the entire continuum, but some of them have a specific focus. So 3 studies in particular are focusing on using criminal justice involvement as an opportunity for seeking and testing and then move into treating. There are 3 studies that focus specifically on trying to implement some type of universal testing within criminal justice with focus on treatment and retention. There are 2 studies that look at medication-assisted treatment for opioid addiction as a mechanism and a way to facilitate HIV care and adherence to HIV care. And then there are 4 studies that are looking at testing and treatment within jails. There's some variation among all of them along those paradigms, but that's sort of the primary focus and emphasis. So then what have we been doing? So how might you get more scientific bang for your buck? Well, we've been involved in a data harmonization activity, and that's what I'm going to spend the next part of my talk focusing on, and exactly what that is and what we mean by that. So what is data harmonization? Well, data harmonization is trying to come up with commensurate measurement across independent studies, which is really important. It's not a single large trial that's done in multiple sites. These are 12 independent studies, very different in certain ways and yet similar in other ways. For harmonization to take place, constructs have to have the same theoretical meaning, measures have to reflect the same construct, variables and scores have to be done identically, or there has to be some way for them to be done commensurately, and values must be scaled in a similar fashion and function equivalently. So why would you want to try to harmonize across independent studies? Well, it offers you economy, it offers you power, and it may offer you the ability to answer questions that your single independent study wouldn't be able to answer. It also helps to increase cross-study, comparability, collaboration, and scientific yield. At the end of the day, what is hoped for is a multi-site pooling to create an integrated data set from which you can do analyses. It's a way to do cross-site replication and comparisons. It facilitates the ability of meta-analyses, and then there are the possibilities for more intricate secondary data analyses. So you get to maximize the gain while hopefully minimizing cost, risk, and time to pay off, and you get to promote construct quantification through integrated data analysis. So I'm going to give you an example of different levels of data harmonization. And I'm going to draw on the area that I know best, which is the addiction field. So this is just kind of a conceptual framework about harmonization around nicotine dependence. So the construct level is nicotine dependence. Then you move down to what's the measure that's going to be used. So the FTND is an instrument that's used to measure nicotine dependence, and then there's the item level, which are what are the different items that make up the specific measure. So complete harmony is that you've got 3 independent studies that are answering 3 very different research questions, but they're all measuring the construct of nicotine dependence, and they're all using the same instrument, and they're all using the same measures. Construct level harmony is where you've got 3 independent studies. They're all pursuing different research questions. They're all going to be measuring nicotine dependence, but they're using 3 different measures for measuring nicotine dependence. However, when you drill down to the item level, you find that there is much overlap and commonality among items, so that item 1 of the FTND, item 3 of the CDS-5, and item 5 of the SDI are almost identical. And there are ways to look at pooling that data. And the same can be said for other items, and that's what the color coding is intended to represent. However, it can get even messier than that, where there is construct measure and partial item level harmony. where you might have 3 different studies that are longitudinal studies that have been conducted at 3 different points in time on adolescents, but with different age groups, all intending to look at internalizing behaviors. In this case, it was depression and anxiety, and I'm going to talk specifically about anxiety in this example. And they may have used the same instruments, but they may have used different items within those instruments. And so there's not 100% overlap, but there are ways to use study, and actually this comes from the published literature, where there was a way to use the second study to create a bridge between the data from study 1 and study 3, and through statistically manipulating the data, create an integrated data set and be able to go about looking at the development of internalizing behaviors over time. So what are we trying to do in the area of seek, test, treat, and retain harmonization at NIDA? Well, this is an example of the constructs. These are the core domains that the group of investigators came together with NIDA to talk about what are some domains across which we would want to harmonize. And you can see that the domains or the construct level are the spokes around the wheel. In some cases, there is a single measure, like for demographics, there's a single demographic measure that has items within it that people are using. Also, though, across the 10 studies, they're collecting their own independent demographic information that helps them to address the question that they're uniquely answering within their study. Certain areas, certain domains, though, have multiple measures. So, for example, when you look at ART adherence, there are several different measures that are included there, and investigators are using a different combination of those particular measures depending, again, on what's happening within that independent study. So complete harmonization, a domain that's going to have some complete harmonization, is around mental health. The mini is being used, and instead of items, you'll see subscales. There's 7 subscales that the investigators are going to use in common. Some investigators are using more than the 7 subscales of the mini. They may be using the full mini, but everyone is going to be collecting data across these particular 7 subscales as they are able to do that from their study. Partial harmonization is seen within the area of substance use. So there's 3 different measures that are currently included. There's one for alcohol, one for drugs, and then some people are going to use urine screens. But not everyone is going to be doing urine screens. Not everybody has the ability to do that, nor the need to do that because of their independent study. But even those that might not have initially thought about collecting alcohol data but were collecting data on illicit drug use as a result of participating in the harmonization efforts are going to now be collecting that data as well. So the process that we've used to kind of get to where we are is we have a set of independent but related studies within an area, which is seek, test, treat, and retain. There's a conceptual framework that was developed of how the studies fit together, but also how they're different from one another and what's unique about them. The funding agency, which was NIDA, has tried to provide some infrastructure to support harmonization efforts. So I'm the sort of point of contact that's worked with the investigators. We've had meetings. I'm trying to help come up with the kind of support that they'll be needing to move forward. We've identified overarching new research questions that are beyond the scope of the single projects to be able to address, determined the data that would be needed to answer those questions and what kinds of domains were going to be defined for harmonization, and then you move into identifying, refining, and agreeing on measures, which is what we're wrapping up and trying to finalize now. Then, of course, it's collect the data, develop the integrated data set, and conduct and analyze and publish your papers based on the integrated data set that's in addition to what you're going to do within your studies. So I want to thank my colleagues at NIDA. I want to thank all of the Seek, Test, and Treat grantees and those who assisted me in particular with this presentation. And I think we're ready for questions.